Michael, I think you're on mute.
Of course I am. Thanks, Rob. Good afternoon, everyone, and welcome to this very special spotlight looking at standard and operating rules, a members-only event for WEDI. I'm Michael McNutt, Director of Education and Events for WEDI, and on behalf of the association, we'd like to thank you for your membership and support as we continue to work with the industry to harmonize administrative and clinical data, improve healthcare exchange, enhance care quality, and reduce cost. Before we begin, I'd like to offer some information about an additional form of educational and informational outreach that WEDI has that many of you might not know about. It's our podcast, The Collective Voice of Health IT. It's a weekly discussion with industry leaders focusing on our most relevant and pressing issues in health IT. We recently celebrated our 5,000th download, so if you haven't checked out The Collective Voice of Health IT, please do so. It's available at wedi.org. Apple Podcasts, Spotify, and wherever you download podcasts. If you happen to be on Apple Podcasts, feel free to send us a review. We'd greatly appreciate it. And now, without any further ado, it's my pleasure to hand it over to my colleague, WEDI's VP of Federal Affairs, Rob Tennant.
Thank you, Michael. And let me add my welcome and also encourage you to check out our podcast. We have, I think, now 59, and all of them are absolutely fascinating and a really good glimpse into the world of these leaders. And so I would certainly encourage you to download them. I also wanted to remind you of the event we're holding next week on the 16th. This is going to be the No Surprises Act National Summit, where we'll be focusing in on the good faith estimate and advanced explanation of benefits. And from talking to WEDI members, this is going to prove to be a very significant challenge. You can see here we have a mountain in the back here. It's going to be quite a climb to implement this these regulations. So a good opportunity for you to come, not just listen, but participate and share your views on these issues. We plan to issue a report to the government following the summit. So this will be a good opportunity to share your views on these issues. But with that, let's turn to our list of wonderful speakers. We have John Hill and Margaret Weicker here from NCPDP, the National Council for Prescription Drug Programs. We'll start with them, then we'll move on to X12, HL7, and then we'll end with a discussion from CAQH Core. So this is, again, an opportunity for you not only to learn and listen to our speakers, but also to ask questions. We have a very lively group of participants from the list I've seen. And don't be shy. If you've got questions for our speakers, please enter them in the chat. They will be reviewing the chat as they go through, so they may be able to answer them on the fly. But if not, we'll have a Q&A session at the end of our 4 presentations where we can address any outstanding issues. So with that, I am very pleased to turn it over to John to begin our presentations.
Thank you, Michael and Robert, in hosting today's event. I'm John Hill, Executive Vice President and General Manager for NCPDP, and I'm very pleased to be presenting to you today and welcome the opportunity to move our collaboration forward. To level set, NCPDP is a not-for-profit, multi-stakeholder forum for developing and promoting industry standards and business solutions that improve patient safety and health outcomes, while also decreasing costs. The work of the organization is accomplished through our members who bring a high-level expertise and diverse perspective to our forum. NCPDP currently has 3 membership segments, including producer-provider, payer processor, and vendor general interest. Currently, we have over 1,500 volunteer members that support developing and improving our standards. NCPDP standards are named in federal legislation, including HIPAA, MMA, high-tech, and meaningful use. We advise regulatory agencies and actively participate in the rulemaking process. We also educate legislators about NCPP's problem-solving forum and consensus solutions and serve as a resource for policymakers. As directed by the NCPP Board of Trustees in 2019, the NCPP executive staff embarked on developing our inaugural 3-year strategic plan, which included input from NCPP Board, NCPP executive staff, Horizon Government Affairs to support regulatory requirements, and NCPP general membership. Through this process, the plan was approved by the board and has been socialized with our membership over the last year, with the primary focus supporting 2 overarching initiatives. 1, standards development, ensuring NCPP develops standards that are relevant to industry needs to advance patient care, and 2, organizational excellence, ensuring NCPP garners the people and resources, as well as refines the processes needed to advance our vision and purpose. During this next section, I'm going to focus on some current standard initiatives we believe this group would be interested in. Regarding real-time prescription benefit standard, we have asked for the real-time benefit standard version 12 to be adopted in 42 CFR 423.160. And I've provided a link to our letter and recommendation for your records in supporting Medicare Part D. The Karen Alliance developed a consumer-facing real-time pharmacy benefit standard, and FHIR. NCPP standard is used by the prescriber pharmacist. The FHIR-based standard used some of our values and is loosely based on the real-time pharmacy benefit beta version. HL7 is undertaking a project, HL7 Pharmacy Work Group, and NCPP members, including our current Board of Trustee Vice Chair, Pooja Barbara from Point of Care Partners, to update the FHIR standard based on version 12. We also have a consumer-facing sub-task group that will monitor the work of HL7. We decided not to create our own version of a consumer-facing standard. The NCPP Foundation has funded a project where Johns Hopkins Medicine Research Study has proven that patients can save time and money on their medication when physicians and pharmacy industry technology partners implement NCPP's real-time prescription benefit standard. Average out-of-pocket medication cost savings for the patient at the time of dispensing was $21.40, with the highest cost savings at dispensing being more than $1,000. You can learn more about the study and the funding by the NCPP Foundation through the link that I have provided. Another key initiative to support our 3-year plan is minimizing the time it takes in developing standards to implementation. A strategic plan committee subcommittee has completed analysis regarding this effort over this year and have developed a swim lane analysis to chart the time in completing current NCPP standards. It was discovered through this analysis the average time for MMA standards is approximately 4.5 years, and HIPAA standards take an average of 6 years. I have provided an entire analysis for your review in the appendix of this presentation. In our initial findings of the SWOT analysis, membership awareness of standards development process is critical to improve engagement and collaboration that can speed up processes. We also need to be formalizing a staggered approach that will alleviate membership concerns with parallel implementation of multiple standards. Also, we would like to look at timelines for regulatory processes that we understand are beyond NCPP's control, but there may be opportunities to suggest shorter implementation timeline to regulatory agencies if membership can commit. Opportunities to shorten internal processes must include considerations for our ANSI compliance as well. Additional considerations that this subcommittee will be working on is bridging the communication gaps between government agencies, improving handoffs and partnerships with other SDEOs, and enhancing trading partner awareness of areas where NCPP can help. We also want to encourage development of technical enablers that can fast track exchange of new data elements, and also exploring the role of the foundation research in increasing speed to standard implementation. In addition, NCPP is in full discovery phase to determine the role we can play in supporting value-based arrangements. The NCPP Strategic Planning Subcommittee developed this graphic, which has been socialized at our virtual annual conference this past June and will support our upcoming educational summit. This graphic documents the two tracks NCPP is considering: one, clinical considerations, and two, data reporting considerations, and how to improve workflow and communicate in real time within value-based care models. To support this initial engagement, we have met with payers and processor industry leads such as the HGA Coalition for Affordable Healthcare, Amicus RX, and AstraZeneca to garner a manufacturer view. As we begin this evaluation to determine the future standards for VBA, these organizations reported success depends on healthcare providers and payers having access to end-to-end exchange and patient robust information and having standard means to capture, maintain, and exchange that information. Initially, our membership segment organizations have indicated a willingness to participate towards achievement, advancing this issue for NCPP. NCPP has also completed a joint presentation as well with PQA to promote an educational webinar that supports NCPP Workgroup 18 specialty and value-based models, including standards, reporting, and measurements, and have identified alignment between VBA and other NCPP initiatives. Additional next steps for the subcommittee, which will be supported by NCPP's upcoming Ed Summit, scheduled for November 15 and 16, around this topic for VBA are the following: performing an analysis of existing standards and transactions to assess what NCPP is currently capable of supporting in order to share comprehensive data points that payers and providers are looking for, and evaluating HL7 and the resources they are creating that could be supportive of value-based arrangements, and making sure that any resources they have can tie back to NCPP standards. And finally, we also plan to reach out to the Office of the National Coordinator for Health Information Technology, ONC, to discuss their strategic plan and how NCPP can support the agency and leverage the HGA coalitions to assess what information is valuable and needed by providers and payers. NCPP has also been a new innovation through our national facilitator model. Congress continues to demonstrate a strong bipartisan commitment to addressing both the COVID-19 pandemic and opioid epidemic. Despite these efforts, little action has been taken to support healthcare providers with actionable tools, enabling them to access and share timely information. Healthcare providers working on the front lines of public health crises, such as the coronavirus pandemic, need actionable tools, enabling them to access and share information in order to prevent and slow down the spread of diseases. NCPP, through its consensus building process, has developed and expanded our standards-based model to support efforts to monitor national disease diagnosis, progression, treatment, and vaccination success. For over 7 years, NCPP, through its advocacy efforts, has been collaborating with industry leaders, government agencies, and NCPP membership in combating the opioid crisis to support the need for real-time data to enhance in-workflow capabilities. In addition to managing in-workflow enhancements for epidemics, NCPP standards-based facilitator model aids providers in testing, treatment, and vaccination efforts during a public healthcare crisis for pandemics. Utilizing existing standards for readily implementation solutions, our facilitator model leverages existing bidirectional interoperability industry standards that are widely used nationwide by prescribers and dispensers today. The NCPP script standard used to support electronic prescribing is named under state and federal law, including MMA. This standard enables the exchange of prescription-related information between prescriber and pharmacist, and the NCPP telecom standard named under HIPAA is used to enable the exchange of information between pharmacists and payers. This model supports improved real-time clinical data exchange and makes best effort in minimizing pharmacy burden and having to step out of workflow for critical data collection needs for both pandemics, and epidemics. Based on the direction and approval of the NCPP trustees, NCPP has entered into an alliance agreement with SDC Health to support the completion of a national facilitator model to provide real-time prescription information to pharmacists and providers at point of care to combat the COVID-19 and opioid crisis facing the United States today. With the current focus on COVID-19, we believe SDC Health is the right technical partner to support the framework established for the national facilitator model. NCPP and SDC Health will lead this initial phase to support the position of the Biden administration, with the understanding there's currently $2.5 billion in potential funding to support centralized COVID-19 reporting system that would focus on laboratory results and other reportable conditions. Next steps include completing a proof of concept with SDC Health to demonstrate the value of the national facilitator model in combating the current pandemic facing us today, and to be presented to key government agencies. The second phase will include the evaluation of potential partners to support the needed in-workflow requirements, leveraging NCPP standards for the opioid epidemic to support prescription drug monitoring programs to improve overall interoperability. In closing, I wanted to highlight the good work we do with other SDOs. For example, with HL7, we have supported the pharmacist e-care plan, specialty enrollment, and with our good friends at X12, the exchanging inventory information between manufacturers and specialty pharmacy implementation guide, and HIPAA transaction 835 remittance advice, and the 270-271 eligibility request response. And with CAQH Core, we participated in groups where the rules are being created or modified for X12 transaction pharmacy use. They have also added a section for pharmacy to their EFT, ERA enrollment data sets operating rule. We continue to look forward in working with these groups and WEDI in advancing the in-workflow needs to improve interoperability through NCPP standards. Again, we appreciate the time today and look forward to additional questions and Q&A during today's presentations.
Wonderful. Thank you, John. And I think we're going to move to Kathy Shepard. Kathy, if you want to share your screen, if you have some slides. Kathy, you're on mute if you're trying to speak.
Okay, is that better?
That's perfect, yeah.
What I said was I am having trouble with my PowerPoint, and I am pivoting as fast as I can to show a PDF.
That, or you can send the slides to Michael and he can pull them up.
I am not sure that I can at this moment,
Okay.
but you guys, it's a great group of friends. You guys don't mind if I show my difficulties here? I was all ready before I tried to look at something. I should
It's
never have
coming up.
done that.
Yeah, no, it looks good.
All right, let me just switch to full screen. Well, maybe I won't. Okay, I'll just do it this way. I'm sorry, guys. I don't usually have technical trouble. That's what I get for trying to do too many things at once. So good afternoon, and thanks to WEDI for having me here today. Thanks, John, for that great NCPDP overview. That was a lot of information packed in just a few minutes, and I was taking notes as fast as I could. So going back to what we're talking about today, we're trying to get some level setting about where we are and what's going on. I have some slides in the front of my deck that are more appropriate for, you know what, I know what's wrong with my presentation. Give me 1 second. Ha, there we go. I thought that I switched off the PowerPoint that wasn't working, but I did not. Okay, somebody tell me where full screen is. I thought it was right here. Okay, well, the slides will look better here anyway. I really feel embarrassed today. I never do this. Everybody post in the chat that you don't mind.
No problem. I think I did see the full screen option though, when you pulled up right down third
Oh,
from the
right
bottom.
here. Thank you, Rob. Thank you. All right, now we're on board.
There we go.
So I have some slides at the front that are going to be just review for this group, but I know that WEDI's going to post them, and I'd like to give everybody a little broad overview. So as I slowly parse through these introductory slides, if you have questions, you can put them in the chat. We can talk about them during the question and answer period at the end. I'm certain that there's nothing in these slides that everyone on this call doesn't already know. So let's talk about what we came today. I'm sorry, was that somebody trying to ask a question? Nope. Okay. One thing that we wanted to talk about today is what are the things that X12 is focused on right now? And as usual, and the same as everybody else on this call, we are focusing on a number of things all at once. We want to make sure that we're distributing mission critical data using technology that meets the needs of the implementers. We want to standardize the data content and deliver it in trusted syntaxes and emerging syntaxes. We want to balance the diverse needs of many different stakeholders in the healthcare industry. We want to simplify the workflows. We want to deliver products annually. We want to make the products even more accessible. And we want to listen and respond to feedback, both internal and external. So those are the primary things we're trying to do as we walk through this ever-changing landscape that some might call a minefield right now, with so much being thrown at every organization, whether they're an implementer or an SDO or an operating rule entity. So you've heard me talk at several WEDI presentations about our new maintenance process that people often refer to as ARC, to remind you that it's the annual release cycle. It's simpler and faster, and it is in play. So keeping in mind that this enhancement to this annual schedule was based on internal and external feedback that people provided to us about how X12 could make stepping forward to new versions and implementing on a regular basis easier and less intimidating. So ARC is intended to streamline the processes on X12 side to support rapid response to new and evolving business needs and federal and state regulations. And I don't think anybody on this call is smiling at that, because there are certainly a lot of business needs and state and federal regulations that are popping onto our landscape. It seems like weekly. We want to enable a reliable annual publication schedule so that implementers and regulators know what to expect and when to expect it. We're proud that ARC has reduced the burden on our X12 member representatives, leaving them free to be subject matter experts and not necessarily typists or spreadsheet keepers. We are also excited that ARC reduces the burden on implementers. Going forward, revisions will be processed in smaller increments, which means that it will take far less time, cost less, and will require less regression and other kinds of end-to-end testing to put updates in place. The basic circle of how this works is depicted on this screen, and it's a circle because it never stops. We will just be at different locations of this cycle for different maintenance requests over time. And I sometimes use the example that this is kind of like one of those traffic circles instead of a stop sign or a stoplight. There's not a lot of stopping and starting. We're just going to keep things moving through this circle. Those of you who have already looked will recognize this slide as a representation of these annual publications in X12's viewer. And I know it's hard to see the details on a slide that you grab as the screen, but you can see, if you squint really hard, that each of the X12 versions is notated in the technical report library with the year that it was published and the version of the X12 standard that is referenced in the set of work that is under that each breakdown. So let's talk for a minute about GLASS. GLASS is our online viewer. It's been in use for a couple of years now. It's powerful and much more convenient than carrying around black and white or blue and white books for those of you that are as old as dirt like I am, and even more convenient than having PDFs that you have to keep track of within your organization. It allows quick and immediate access to all versions of the X12 EDI standard and to many versions of implementation guides, technical reports, design rules, and other reference information. This is the first time that X12 has made this amount of information available to people in this way, and the number of subscribers is growing steadily. We have feedback virtually every day from people who are just thrilled that they can get access to the details of the standard, the code sets, the elements, the segments at their fingertips at their desk instead of having to go off on a search. If you haven't had a chance to look at GLASS, then I suggest that it might be worth your time to go and check it out. I want to stop here for a minute and put these 3 bullets up so that everyone is very clear. X12 supports new technologies. We are not threatened by those technologies, and we believe that those technologies bring great value to the industry. The link between new and proven technologies is that the metadata needs to be the foundation that enables successful and interoperable use of the various syntaxes and delivery systems. We don't have that standard foundation as the base, then interoperability becomes very complicated and very difficult. The metadata that we have in play is mature, well understood, and proven, and we're happy to be pairing it with emerging and existing technologies to present opportunities for entities to leverage the technology investments they've already made and the technology investments that they want to make going forward. So part of that for X12 has always been a great desire to satisfy the industry's continual requests for in-context references. It can be difficult for implementers if they have to go look 6 or 7 places to make sure they understand all the requirements that are in place at a particular place in the implementation guides, business rules, or data content instructions. So along that path, we've been working very significantly with DaVinci Project, and we have crosswalk information available now in several of the X12 implementation guides published in GLASS in the 5010 version. So if there are implementers who are implementing some of those DaVinci implementation guide instructions, they will find the field names from DaVinci and the element names in X12 are directly and distinctly cross-referenced, which should enable standardized, consistent, and predictable transactions as implementers move between FHIR resources and X12 syntax. We're very excited about this, and DaVinci and HL7 have been including that in their recent Connectathons. X12 is also gathering feedback and information from our implementers and our membership about that, and DaVinci and X12 will continue to walk hand in hand down the path to make sure that we keep our instructions in sync and that we continue to improve them over time. We also recently published the inclusion of the CAQH core operating rule cross-references in the X12 implementation guides. So the mandated operating rules can be located also in the GLASS versions of the implementation guides. And that link will take you to CAQH core's full operating rule online information. So we're excited about the number of people who have already indicated that this is going to be extremely helpful to them. And just so you know, we now have a going and growing list of additional mappings, crosswalkings, and external references that implementers think would be important to simplify their implementations in the future. Let's pivot a little bit and talk about some of the current initiatives, which was the second focus for today. as I said on the previous slide, DaVinci and X12 are going to continue to create these data crosswalks that will facilitate consistent data use between the DaVinci pre and post processes and X12's authorization, as well as more crosswalking between other DaVinci project processes and X12's implementation guides. X12 is also working on specific FHIR tools that will develop fully bidirectional mapping instructions, which hasn't always been possible so far in the DaVinci X12 mapping exercises. And we'll have more information about that as we get further along in the process. We're also working with HL7 to focus on cross-utilization of code lists so that we reduce inconsistency and duplication. And we are hopeful that some of that work will result in another set of simplifications for healthcare implementers who don't have to change code values between the various syntaxes that they're putting into place. Another thing that we're doing right now is a pilot related to use case specific implementation guides. I expect that all of you know and understand that X12's healthcare related implementation guides, for the most part, contain comprehensive instructions for several variations of a specific business function. Many implementers and federal and state agencies have requested strongly that X12 also provide more narrowly focused instructions to describe data required for very specific business cases. And specifically, they want us to pair up some use cases that fall in line with the DaVinci use cases so that it's clear how the data would move through the flow if implementers are going back and forth between the syntaxes. So X12 and DaVinci and the DaVinci project are collaborating to produce a new implementation guide as a proof of concept, a little bit complex, so that would be the slip of the tongue there, that supports the No Surprises Act, tightly integrates data flow between X12 and FHIR syntaxes, and focuses narrowly on a single use case. More information about this use case specific implementation guide is going to be available soon. Of course, it will be rolled out to our participants and DaVinci participants first, and then we will make some broad announcements so that everybody in the industry will have a chance to look at the work and see what's being done to facilitate these kind of pairings of technologies. Sometimes people don't understand the number of places that X12 is partnering and collaborating. So we put together this partial list for collaborations that this group might recognize and understand. There is so much work going on in the industry right now that there's no possible way any of us can keep up with all of it. So we're all working together in these partnerships to make sure that we know what's going on with other groups and that we can best utilize the subject matter expertise across the industry. We also regularly interact with other organizations, several of the ANSI groups, Project USAT, HL7's Gender Harmony Work Group, and of course, we're always working with WEDI to find out where we can best solve problems and introduce new solutions. We recently put on our first series of educations to illustrate how X12 EDI and FHIR are cooperating and how they align in the pre-authorization and authorization transactions. The first series was exclusively for X12 member representatives, and it was very well attended. We received a lot of positive feedback. We also received some suggestions that we want to put into play. So the next series of this two-set training will start in December. We don't have exact dates yet, but you can watch for that announcement. When we have those dates, we will pass them over to Michael so that he can publish them to the attendees of this conference or to the full WEDI membership, however they want to do that. These are two sessions trying to explain at a very high level to what we started with was two X12 members who didn't have a very good understanding of FHIR, what it involved, and how it would interact with X12 EDI. What we immediately learned was that there are a very large audience of non-members who also aren't sure they understand these relationships, and they want to be able to access these sessions. So we believe that we will have at least 2 or 3 more that are open to members and non-members. And then given the current demand, we're planning to put up a reusable and consumable video of this training so that people can refresh themselves at any time, and that people can watch this explanation material whenever they're ready for it instead of on a set schedule. We think that will satisfy a lot of the requests that we're getting related to this session, and we're happy to hear your thoughts on that too. Another thing that we're doing in this small list of hardly any tasks is preparing our recommendations for new versions for mandate. We recently conducted an industry survey. Hopefully most or all of your organizations participated in that survey. We did have a very strong response to it. We were able to gather a lot of very useful information. Those results are being prettified, how's that? And they will be posted soon on x12.org. Again, we will let people know when those survey results are available for viewing. Based on the survey and the information that we collected there, we're actively working on recommendations that will advance to new versions of many of the mandated 5010 implementation guides, along with recommendations for new transactions that for which a mandate would be helpful to the industry. And we have a long list of those from various components of the healthcare industry. So we know some prioritization will have to be done. But we're excited that there are so many people that are interested in additional transactions that will smooth their business processes. The recommendations that we move forward are going to be based on functional improvements or opportunities to standardize mission critical business messages. And we don't intend to move any transactions forward just for the sake of moving them forward. So the industry should recognize tremendous value when we get to the end of what we all know is a somewhat slow federal process, but the movement is in play, and more information will be coming out regularly about this, the recommendations and the next steps as we move them forward. The ASC officers, the X12N officers, and X12N workgroup chairs are currently finalizing functional improvement summaries and technical impact statements that will accompany the formal recommendations. And these documents are specifically focused towards the requests of HHS groups and NCVHS so that we can provide as much information as possible on the front end of this discussion and make it available to people through the whole discussion. Again, the information that we put together will be shared with X12 member representatives first, and then public announcements will follow, including specific announcements that we'll send over to Michael to share with the WEDI membership. That is all I was planning to talk about today. I didn't remember to turn on a timer, so Michael, I have no idea how I did for time, but thanks again to everybody for listening today and for letting us be part of these industry-focused groups that help us spread the work and the benefit across the entire healthcare industry. I know we have questions available today, but if you think of some later, you can also post them at x12.org feedback, and X12 will respond to you with what the next steps would be if it's a suggestion, or we will consider the ideas and feedback as we move forward. If you want to stay connected, you can become a member. That's a great way to stay connected. Also a great way to help develop the next versions of all of the standards and implementation guides. And you can stay informed by following us on Twitter and or LinkedIn. So thank you again for letting me have this opportunity today. And I will pass it back over to Da Vinci, I believe.
Kathy, thank you. That was excellent. Great discussion, a great overview of the wonderful work you're doing. We're going to switch over to HL7 Da Vinci. We're very pleased to have Tony Benson, Dawson Keegan, and Leslie Ambrose give the overview. And with that, you got the slides up. Take it away.
All right, thank you, everyone. My name is Tony Benson. I am a senior consultant with Blue Cross and Blue Shield of Alabama. Blue Cross and Blue Shield of Alabama is a founding member of Da Vinci and the Da Vinci Project. I was also co-chair with Mark Scrimshire for the initial Payer Data Exchange, or PDEX, implementation guide. So I think most of you know, but if not, Da Vinci was created out of an idea to rapidly develop implementation guides for specific use cases from a diverse multi-stakeholder group, using FHIR as the foundation for our development. The end goal of Da Vinci has always been for our membership and broader community to pick up these guides, implement them, and advance interoperability. I think simply stated, Da Vinci is a group of payers, providers, and HIT partners that are paving the way for value-based care data exchange that is critical for interoperability. If you've seen a Da Vinci presentation before, you've probably seen this slide, so I won't stay on it too long. But one thing I do want to mention is, on the far left side, the number of providers that we have as members now has grown significantly. As a founding member, I remember, we admittedly struggled to bring providers on at the very beginning, but we now have provider organizations that are developing these implementation guides in concert with the rest of Da Vinci. They're implementing them and using them in real world scenarios. So, I think this just goes to show the broad membership stakeholder that Da Vinci has. Again, this is one of our standard slides. This is our use case maturity. We break it down under domains. So we have, different domains. Implementation guides can live under multiple domains. So you might see some like Payer Data Exchange living under Clinical Data Exchange and Member Access. A lot of these guides are going out to ballot in January. We're going to focus on 3 today. We're going to focus on Payer Data Exchange, or PDEX, Patient Cost Transparency, or PCT, and Risk Adjustment, which did not get an acronym, I don't believe. We like our acronyms at Da Vinci. But more than that, there are other guides that will be out for ballot in January at HL7. So if you are a voting member at HL7, please sign up, review our implementation guides, and comment and ballot on it. I think this slide does a really good job of showing the progression of payer-to-payer, with the end goal of the member having access to their data as they move from plan to plan. We all know that CMS came out with their interoperability rules that did not name a standard for the exchange of data between payers. Then they released a proposed rule, and then that went final that came back, which did mention or reference the Payer Data Exchange, or PDEX, implementation guide. Obviously since then, we've seen CMS exercise their enforcement discretion for that payer-to-payer mandate until further rulemaking is provided. But I think one thing I want to point out here is many of our Da Vinci members are still moving forward using PDEX as the solution for their payer-to-payer data exchange using the FHIR-based APIs. So we are not stopping. CMS in their enforcement discretion encouraged payers to keep moving forward if you were building out APIs, and a lot of our community took action and are continuing to build out a FHIR-based API using PDEX for payer-to-payer data exchange. The deck will be available after this presentation, so I won't spend much time here, but this will give you some direct links to CMS FAQs, some of the Da Vinci dashboards and implementation guides. There is a lot more on Confluence, so if you are familiar or not, you can go out to the HL7 Confluence website, and you can get to the Da Vinci site, which has a lot of good information on all of our use cases, not just peer-to-peer. So the next implementation guide that we'll talk about is the Patient Cost Transparency. It is one of our newer work groups that has spun up, and it has garnered a lot of attention. It's one of our more popular work groups. It is at 10 o'clock Central Standard Time on Friday. These calls are open to the public, so we would love for you to join us. It's a very lively discussion. As Rob stated at the beginning, this is a very difficult topic, and we're tackling it as best we can. So this slide depicts what we're working on. So the patient cost transparency is focusing on the good faith estimate, or the GFE, from the servicing provider, the submission of that GFE to the payer, and then the payer returning the advanced DOB to the patient, as well as the provider. So the provider is not required to be returned per the CAA, but Da Vinci recognizes the importance of that and has added that as a component into this patient cost transparency implementation guide. Yeah, I think it's important to remember that this guide supports the requirements of the CAA and the advanced DOB, but we're not building it specifically for that law. It's being built from a need that the industry has, so we could see additional functionality or other use cases within this implementation guide. Again, I think we've all said this is a very difficult problem to solve. So we're starting with a small bite of the apple for phase one. We're starting with a single provider, good faith estimate to the payer, with the advanced DOB returning back to the payer. Kathy mentioned about the X12 to FHIR mapping that is available if it is supported by your intermediary or clearinghouse. Phase two will include possibly more of the convening provider to provider conversation, maybe using a Smart on FHIR app, or even shopping tools to help the member with the end goal of price transparency. I mentioned earlier that a lot of our guides are going to ballot. This is one of them. It goes to ballot in January. The consensus opened Monday, so you can go out if you're an HL7 member, sign up now to ballot and vote on these implementation guides and comment on them, and we would love for you to do that. This slide, you can see the progression we've made. The one thing, again, I want to really hit on is we're targeting that January 2022 HL7 ballot. So again, it is actively being developed and will be available for the ballot in January. The other use case that we'll be discussing, it's a fairly new use case. It's our risk adjustment use case. The risk adjustment here is related to improving the risk score accuracy, or the HCCs, for the member. It's not about at risk or risk models for providers. But this implementation guide is accomplished by communicating the previously coded HCCs or suspected conditions to the provider, who can then appropriately document the patient's condition each year. And that each year is important. I use the analogy, if you're not familiar with the risk adjustment model, every year you have to recode or redocument within the medical record the patient's conditions or comorbidities. So every year, a patient who has an amputated limb, that limb grows back. And if the physician doesn't document that patient has an amputated limb, it doesn't count towards their HCCs or their risk score. It's also important to note that this IG is not building the mechanism to send those codified conditions back to the payer. That is, at this point, still expected to be done on the claim. So this is just to inform the physician of those conditions that they need to code. This is also planning to ballot during the January 22 cycle. So again, it is out there now. You can sign up to vote on this implementation guide. Again, these are just some of the elements that are identified within that implementation guide. Again, it talks about the HCCs and suspected diagnosis. There are talks now of phase 2 for the risk adjustment model in the implementation guide. You can see the current build if you go to build.fire.org, and the links are on the right-hand side there. So again, feel free to join us Thursdays from 3 to 4 Eastern. These are, again, open to the public. And I think that was it. Just join the Da Vinci community. It is open. We are actively looking for participants to help us develop these implementation guides and drive interoperability. So you can reach out to me, myself, Jocelyn, any of the PMO team, and we'll be happy to help. So I think that's all I have.
Thank you, Tony. Excellent presentation. And thank you to Jocelyn and Leslie for their fast typing in the chat as well, putting in all of the great resources. My pleasure to introduce our next speaker, Aaron Weber from CAQH Core. And Aaron, I see you've got your slides up. Take it away.
Great. Thanks, Rob. And hopefully everyone can see my slides. Batting cleanup today is CAQH Core. Most of you, I'm sure, are familiar with our organization. We are an industry-led alliance of health plans, providers, vendors, government organizations, associations, coming together to develop operating rules, which are really business rules to support the exchange of healthcare data. We see our role not only as to supporting the development of the operating rules through our subgroups and work groups with our participating organization, but also to drive implementation through our certification program, educate the industry through sessions like this and webinars and presentations throughout the industry, and with an increasing focus on measuring the impact of our work and others in the industry to drive automation. We are governed by a multi-stakeholder board, and many of the organizations, actually almost all of the organizations on the call today, sit on our board as advisors, which shows the importance of coordinating and working across these various efforts. This next slide lays out the current CAQH Core operating rules. There are 8 sets of operating rules available now for industry implementation. Those in purple are federally mandated under HIPAA. The other rules are available for voluntary implementation. And we continue to build on these rules over time. And I'll talk more about some of the updates that we're making in a second. I mentioned our certification program. We are continually supporting the ability for organizations to demonstrate their conformance with the operating rules. I actually think that the number on the screen is now outdated, and as of today, I think we are at 398 certifications, so approaching the 400 mark. We recently launched a recertification program as well, so organizations are now recertifying their compliance with the operating rules every 3 years to ensure ongoing compliance and to add in updated requirements over time. I'm going to talk now about some of the work that we are doing this year and what's in flight. We have our participating organizations have been really focused on developing new rules and updating existing rules this year. I think historically we have balanced between some years we call rule development years and other years are more focused on adoption and implementation. And this is certainly a development year for us. And so we appreciate all of your engagement in the efforts to drive this work towards what we hope is a formal voting and balloting period at the end of this year into the beginning of next year. So on the next few slides, I'm going to highlight a couple different efforts we have underway. The first is the development of attachments operating rules for both prior authorization and claims. as well as an update to our infrastructure operating rules. Many of you may remember that those rules were first developed about 10 plus years ago. So some of those requirements need to be updated as technology and the industry has evolved over time. We are also working to update our eligibility operating rules as well. And finally, I'm excited to share some information about the work that CAQH core participants have been doing related to the advanced explanation of benefits requirements in the No Surprises Act. And of course, we have ongoing maintenance of several of our operating rules, including the core code combinations to support the denial and adjustment codes on the electronic remittance device transactions. I'm not going to get into a lot of details on attachments. I know that this group is very well versed in the challenges and status of the work being done and the recommendations that have been set forth by the industry and by the federal advisory bodies to CMS. We continue to wait for an attachment standards. And for many years, the core participants and our board just felt that it was worth waiting for a standard to come forward. But as that has still not happened, the board and the participants decided to move forward with developing operating rules to help the industry add some consistency in helping to automate the exchange of attachments for both claims and prior authorizations. So we launched some work back in 2020, which resulted in the release of a white paper with opportunity areas for the industry to create some uniformity and automation. That work was done by an advisory group of CAQH core participants. And most recently, we have moved to work on operating rules. And these operating rules are based on the recommendations that the National Committee on Vital and Health Statistics has set forward to CMS related to an attachment standard, and also the information that is in the unified agenda on the potential requirements of a attachments NPRM. For both use cases, there is an infrastructure rule and a draft data content rule that address the various components of the electronic exchange of attachments. So when we think about prior authorization, all of the traditional core operating rule infrastructure requirements have been considered by the core participants and are included in the draft rules. Around real-time response time, batch response time requirements, minimum document size and amount of data, standard method and response time for receiving system to return errors to the provider, system availability, and common flow and format of companion guides. The prior auth data content rule includes reassociation requirements, as well as consistent reference data between the prior authorization request and associated attachments. Similar requirements can be found in the draft claim attachment operating rules. Again, there is an infrastructure rule and a data content rule. The infrastructure rule includes the traditional infrastructure requirements related to response time, system availability. It also establishes electronic policy access requirements and specifies support for multiple electronic attachments to support a single claim submission. And that data content rule then aligns with the prior authorization data content requirements and requires health plans to use appropriate links to request most specific additional information. I'll talk about the updates to our eligibility rules next, and then I'll talk about how all of this work is going to tie together in our formal voting and approval processes. Many of you are aware of the current requirements in the eligibility and benefits data content rule that was federally mandated. It includes requirements for including a great deal of patient financial information in the eligibility transaction, as well as support for 51 service type codes, requirements related to last name normalization, error reporting, and the ability for vendors to detect and extract data elements to which the data content rules apply as returned by the health plan. So This initial rule really provided a lot of valuable information for providers as eligibility transactions became more common in the industry. But it was time the core participants felt to add new requirements. And so this, about a year ago, the participants went through a process of prioritizing opportunity areas for enhancements to the rule. And there are 6 areas that have been included in the draft updated requirements related to telemedicine, additional service type codes, remaining coverage benefits, procedure codes, prior authorization, certification, and tiered benefit information. And finally, I mentioned updates to our infrastructure rule requirements. These are still under discussion by the CAQH Core Review Work Group right now. Each set of core operating rules includes an infrastructure rule, but some of those requirements, like system availability being set at 86% and response time, were really progressive, 10 years ago when these requirements were developed, but the industry has evolved. So the participants right now are working to determine what are the current requirement, what should the current requirements be to align with our evolving industry. So more to come on where the core participants land on that. So next steps for all 4 of these efforts that I mentioned, the new attachments rules for prior authorization and claims, eligibility and benefit data content updates, and the infrastructure updates, they will be going through our formal voting process. So there will be a review work group ballot in the coming weeks where all of the organizations who participate in our review work group provide feedback and vote on the rules. Then there is an all core vote within CAQH core organizations that implement the rules and use the transactions, have that sort of final say, as they're the ones that are going to be investing the resources to implement the rules. And then finally, we anticipate in February, assuming that the prior process proceeds as expected, that the board will vote and the rules will be available for implementation early next year. And then lastly, I just want to spotlight the work that we've been doing within the CAQH Core Advanced Explanation of Benefits Advisory Group. This was a group that was formed in August to help respond to some of the requirements in the No Surprises Act. There are, and I think we all heard lots of industry conversations and discussions around the variety of approaches that could be used to support implementation of those advanced EOB requirements. But the industry also had a lot of concerns around not taking common approaches and proprietary methods and the costs that may be associated if these requirements were not addressed in a uniform way. So the Advanced EOB Advisory Group came together to develop recommendations for its first use case, which was really focused on the exchange of that good faith estimate information between providers and health plans. And I'm pleased to share with everyone today that that guidance document and the recommendations that came out of the work of that group were released today. Hopefully Daphne will be adding a link in the chat related to recommendations for messaging standards, connectivity methods, and data content needed to successfully exchange this information. And we'll be having a webinar next week with more information and background on those requirements. There's a lot of work to be done on these requirements. I think it's going to be really important to coordinate and align across the various industry efforts and initiatives to ensure that these requirements are implemented in a meaningful way without adding unnecessary burden to our industry. So with that, I will wrap things up. As always, feel free to ask questions in the chat or reach out to us directly. We encourage you, if your organization is not already participating with CAQH Core, to join us as we tackle some of these pressing issues in healthcare.
Thank you, Erin, and thank you, Daphne, for your fast typing in the chat. I'm going to open it up for questions. I have a few that I wanted to ask the four organizations that we have here. And I'll start with one of the themes that I heard, and that is return on investment. Regardless of the version of standard, the type of standard, we know that it's going to be a heavy lift for the industry. So I wanted just to ask each of you, and maybe we'll go in order. We'll start with NCPDP, John. How does your organization establish ROI, and how important is it to ensure that you get support from the industry and ultimately, of course, from the government? How important is ROI to gaining that support? And John, you might be on mute.
Actually, Rob, I think John had to leave. He had
He had to leave.
He had
Okay.
a hard
well,
out. He had a hard out.
Okay, good. So let's maybe Kathy, if you don't mind.
Sure, that's fine. I think that we'll have different ways to determine ROI based on different particular situations. If there's a very specific federal mandate for something because the Senate and the House want it, that's a different situation than if the SDO has received functionality requests that they're satisfying. So I think that return on investment is important, and we do need to keep track of it, and we do need to be able to describe it. And that's part of the reason why we switched to our annual cycle, because it will be more easy to quantify the value of each set of changes. But I also think that there were times that the ROI may be that we can't afford not to do something. And we'll have to accept different markers or different ways of proving out that kind of ROI.
Gotcha. Good. Tony?
Yeah, I mean, I think, for specific ROI, there's an intrinsic value, for the Da Vinci project. We're cutting our teeth in the Fire API world. And so, it's been not difficult, but the uptake, it was slow, but I can see, it's moving much faster now. The CMS interoperability mandates as a payer specifically has required us to invest in that space. So I think the ROI now moving forward is going to be a lot less as we develop these implementation guides for value-based care.
Erin?
Yeah, thanks, Rob. I agree with Kathy. I think there's varying times when more or less ROI is needed, and willingness of industry to commit resources to demonstrate ROI. In some instances, it makes a lot of sense to pilot something early, make sure there's a strong business case for it. And in other instances, for example, maybe when you have something coming down from the No Surprises Act in Congress with deadlines, you need to move forward. So we're trying to build that into our own models at CAQH Core as we think through how can we build ROI into our certification program? What's the value of case studies when you have individual organizations willing to commit resources, like some of the work we've been doing with the Cleveland Clinic, as well as the CAQH Index, which tracks adoption of the administrative transactions over time.
Excellent. And Janice has asked a question, and she always asks good questions. So, I'll paraphrase, it's a long one, but essentially, and it's one that I think a lot of us have been asking about, and that is the translation between X12 and FHIR, especially when we have a HIPAA requirement to use the X12 standard. So now we have a situation where she says folks are using FHIR at both ends of the transaction that continues to require X12. What are your thoughts, maybe first Kathy, on that? It's certainly a huge issue for the industry.
It is, and I think there's no shortage of discussions that we've had between Da Vinci and X12 leadership to try to decide what's the best path. And I think you heard several times during my little talk that that we think standardized content is the key to making these things truly interoperable. And if we get mature standards on both ends, perhaps we can use the same kind of logic that the government has said in the past, which is if you wanted to create the mandated transaction, you could at a point in time, and you're not obligated to do it. I think we can make suggestions to the regulators about how that should work or what that should be. But I don't think that any of the organizations represented here are going to be able to come out and say, well, this is what the answer is going to be, government, take it or leave it. So again, I think everybody understands the most effective thing is if we can all interchange data in our own preferred syntaxes. And X12 doesn't have any issue with that.
Tony, if you had any thoughts?
No, I mean, I think, Da Vinci recognizes that there is a lot of legacy systems and systems out there that are X12 heavy, and there, for those systems that want to continue using that, there is that intermediary facade approach that Da Vinci creates that allows for that translation, while at the same time allowing it to go fire to fire at both ends. So I think it's flexible in the way that we're building it, and allowing the community to decide how they want to implement.
Excellent. And Janice alludes to the CMS exception process, and I think that might be an interesting topic to explore. There is the ability for an entity to apply for an exception to use a non-standard standard or not a non-adopted standard. Where does that option fit in? And I guess I'll add on the question of, we've tended to look at transactions by version. Are there opportunities, and should we be looking at opportunities to adopt by use case? So for example, if there's a need for a prior authorization standard, but not a need to update a claim standard, is that an option for the industry? Maybe Kathy, I'll start with you.
Oh, that's not an option. That is how we're going to proceed moving forward. You can expect, perhaps this move will be different because it has been a heavy lift from 5010 to where we are today, based in large part on the industry's reluctance to move forward to a new version. X12's been ready for a while, but the value, I think I tried to allude to this when I was talking to, the value of moving forward will be evaluated by functionality. So, and yes, X12 loudly hears the industry saying that use case level implementation guides are very necessary. And, previously it's a pendulum. This industry has a pendulum and it swings back and forth. And at one point, the pendulum said that encyclopedias were better than spelling guides, right? That put everything in that encyclopedia, and we'll dig out what we want from the encyclopedia. That is not the pulse of the industry today. We recognize that. We're working on ways that we can take proven and established implementation guides and break them up into some subpart section, so that people who are really only interested in one particular niche don't have to peer through that implementation guide to find the sections they need. As far as exceptions, I believe that the government's version of their exception process is fairly limited. And for example, as I've heard a number of times, there won't be an exception that says everybody can go forth and start using FHIR instead of this other transaction as an exception. There won't be an exception that says every implementer can move directly to 80/30. The exception process is intended to be just that, a small group that pilots or proves out a direction that the rest of the industry may take. Did I cover all the things you asked in that question, Rob?
Oh, excellent. Yeah. I don't know, Tony or Aaron, if you have some thoughts.
I think that to the exception part, it is very limited in scope to, Da Vinci membership. It has a shelf life, a length of term. So, to Kathy's point, it is not a blanket. You can do it and don't have to look back. I mean, there's a lot of requirements around that exception process. And I am not speaking for HL7, but as a member of HL7, our advancement process is a little different in that going forward, everything that we're developing from R4 forward is backwards compatible, and even some of the regulations that have come out has stated that we could move to a newer version, so we don't have those the HIPAA limitations regarding moving to a new version, to an STU2 or even an STU3, in fire. So it is different, I think, in the HL7 world.
And Rob, I would just add from the operating role perspective, certainly one of the challenges is the lack of regular updates. So when you think about some of the connectivity requirements that are still federally mandated, Core is on version 4 now, which is much more aligned with today's security needs across the industry. Whereas version 1 and version 2 are still technically the federally mandated versions. So we've been thinking also and working with our board and our participating organizations to think about how we're setting expectations moving forward, if not necessarily from a federal mandate perspective, but even from a core certification perspective, to require the most recent version of something or have a floor and not a ceiling in terms of how far people can go in terms of meeting the newest and latest requirements.
Oh, good point. And Janice also mentions the onerous amount of reporting, which I guess is the point of the exception, is really to pilot something new, but also to report back to the government on how that pilot went. So it can use the exception process in its deliberations and moving forward. So it's a double-edged sword. It's more challenging for the entities, but better for the government to get that information. And Sam has asked a good question here. Says, I think that there is an operational concern with flipping to a new X12 version that equates to risk and resources. And so the question is, do we want to fix something that isn't broken? I think that, Kathy, that gets to the point of saying, to your point, maybe there is an opportunity to solve a problem that needs to be solved without having to move to a completely new version of transactions that are working well. Any thoughts on that one?
I think that's right. I think that we can hope that we can get some recognition in a regulatory process that says clarifications that don't really change things but make it easier for implementers should be easier to put into play. But on the other hand, I don't think there's anybody here who is running a text-based editor on one line at a time on a green screen the way we did in 1982. So at some point we have to move forward. I mean, who supports the second version of the Chrome editor? There's some level of you've got to move forward to stay current, otherwise the lift is too heavy when something comes up. But certainly that's not every year or every 5 years even, unless there's functionality that the implementers need.
Yeah, and I think that sort of gets us to another issue. And it was certainly a theme that I heard throughout the program, and that is, it's one thing to develop the standards, it's another thing entirely to get them anointed by the government and implemented. So what are, it's a tough question, but what are some of the roadblocks to getting new standards implemented that the industry could potentially address? We do have the NCBHS, National Committee on Vital and Health Statistics, that sort of uh, sort of acts as a way station or clearinghouse for new concepts and ideas, new versions, new standards. Are there any sort of quick ways that we can accelerate that process?
Well, if
Maybe
we
I'll-
stick,
I'll-
sorry, Robbie,
ahead.
if we
No, no.
stick to things we can control, which as everybody knows, and anybody who participates with NCVHS's brainstorming sessions painfully knows, we can only fix a certain portion of this process. But if we focus on that, I think that the appetite to say we're willing to move forward with small incremental changes on a more regular basis is an important message for the industry to give to the regulators, because we had 50/10 and the X12 was ready to move to 60/20, and the industry said, oh, no, we don't want to, because that was too heavy of a lift from 40/10 to 50/10. So now every time we've kind of poked that, how's it feeling now across the industry, the answer has still been, oh, no, not yet, we're not ready. There's this mandate and ONC is doing this, and this is happening over at NCPDP, so not now. And then we get to a place where we are going, it has to be now. There's all this functionality waiting behind. And then the industry says, oh, it's too big of a lift because there's too many changes. So we need to have a little more realistic decision across the whole continuum. Do we want to consume huge changes every 10 to 15 years, or do we want to consume 20 to 30 changes annually, or 50 changes every 2 or 3 years? I think that methodology, that basic underlying tenet has to be established before we can get to a better place.
Excellent. Tony or Aaron, thoughts on that one?
I would agree with Kathy. The only thing I would add is when you think about the parts we can't control, right, Kathy? There's also been a lot of discussion at those NCVHS meetings too about the pace at which the federal government and the regulatory process operates, and that also being a challenge for the industry, because it is a 2 or 3 year process from the time a new standard or operating rule is proposed until when it is required to be implemented. And we know that the world is evolving very quickly. A lot can change in that time period. And so that's, I think, another, roadblock that the industry feels.
Agree.
Yep. And getting some interesting comments in the chat. Rachel said, conceptually, just like we evolve highways, airplanes, automobiles, etc. Of course, we do know that we haven't been spending on our infrastructure as much as perhaps we should. So we're seeing bridges collapse and things like that. So there's a cost for inaction. I think we can all agree on that. But I wanted just to switch gears a little bit. One of the things that we think is critical is to make sure that every stakeholder group has input into the standards development process and the operating rules. Can you, each of you, just sort of briefly sort of give an overview of how you ensure that you're getting a diverse set of viewpoints that are incorporated into the development process? Maybe Kathy will start with you.
I'm sorry. Can you one more time? I was still thinking about the last comment.
I guess, one of the things that we really need to ensure is that we're getting all stakeholder viewpoints incorporated as we're developing these standards. Can you maybe share some thoughts on how your organization really tries to involve each of the stakeholder groups?
I can. We try to make sure that we have balanced representation, and that's not necessarily what the average person thinks of. We don't say one provider, one payer, one vendor, but ANSI establishes criteria for what is balanced, and we meet those criteria, or we actively recruit until we do meet those criteria to try to make sure everybody's at the table. The other thing that we have done differently in the past than we're going to do in the future is previously all of X12's comment periods or evaluation periods came at the end of all of the development work, of all of the proving and documenting and all of that. So if you're already wrong when you get to the end of hundreds of hours of work, that's a big problem. So under ARC, probably in maybe third quarter 2022, we're going to be ready to roll out another portion of the ARC process, which will be when we get a suggestion for a functionality change, we will gather public comments on that suggestion first before the solution is defined. So if somehow the request is off track to where the rest of the industry believes it's headed, we'll have that information before we ask any of our volunteers to use their expertise to develop a solution. So that's one thing that I think is going to make a big difference going forward. If we move that public input to the front, then we don't invest so much in something that may not be what the industry really wants.
Excellent. Excellent. Erin?
Sure, Rob. Similar to what Kathy mentioned, we work to have representation across the stakeholders among our participating organizations. Our work groups are chaired typically by a provider, a health plan, and a vendor. We do a lot of polling on our education sessions and industry surveys, where we do break down the information by stakeholder group. And I was just thinking about the work group meeting we had last week when we broke down the infrastructure support by stakeholder group, and you could see it was very mixed, and there was a difference among stakeholders in terms of who supported what. And that's part of consensus building, is then how do you bring the group together to move forward with a compromise. And so we are constantly thinking about how to ensure we have that representation, and we will go out and actively recruit it if we don't feel like we have it.
Excellent. Tony?
From a Da Vinci perspective, all of our work groups, we strive to have a member representative as a co-chair. So, a payer, a provider, and an health IT vendor, whether it's an EHR or intermediary, as a co-chair. We also have different industry or community events that we host once or twice a month to try to get the involvement of more broad stakeholders. Again, everything is open to the public and free to participate. And so, we actively, I wouldn't say volunteer people, but we do try to make that commitment to our membership to build and have a diverse membership that is building those implementation guides.
Excellent. Well, before we close, I wanted just to say a couple of things. One, I heard loud and clear that each of the four organizations have a lot going on. They've got a lot of education, a lot of opportunities for input and for knowledge gaining. So we'll be working with each of them to see if we can't collect that in a spot on the WEDI website. So the WEDI membership has a single source where they can go to get more information about what's happening with each of these organizations. And lastly, I wanted to thank each of our speakers and our organizations for their wonderful presentations today. And I think it's the first of many conversations that I think are important. I also heard the need for sharing and collaboration is critical if we're to move ahead as an industry. So with that, I will close the webinar. Encourage you all to join us next week for the No Surprises Act Summit. And with that, thank you again, and we'll talk to you soon.
Thanks, Rob. And thanks to WEDI for holding the session.
Have a good rest of the day, everyone.